Today, we're going to cover the recent focused update of the American Society of Clinical Oncology Guidelines for Systemic Therapy for Melanoma. This guideline was last updated on August 14, 2023. This video also incorporates the current recommendations from the April 2022 and March 2020 publications. The purpose of this guideline is to provide guidance to clinicians regarding the use of systemic therapy for melanoma. The patient population of interest is adults 18 years of age and older with melanoma, both cutaneous and non-cutaneous. This guideline update was developed by a multidisciplinary expert panel of medical, radiation, surgical, and community oncologists, as well as 2 patient representatives and an ASCO guideline staff member with health research methodology expertise. This guideline was developed using the Grading of Recommendations, Assessment, Development, and Evaluation Evidence to Decision Framework, also known as GRADE. This framework categorizes recommendations by type: evidence-based, formal consensus, informal consensus, or no recommendation; strength of recommendation: strong, moderate, or weak; evidence quality: high, moderate, low, very low, or insufficient; and a benefits-harms assessment. Either the benefits outweigh the harms outweigh the benefits, or a relative balance of benefits and harms. Introduction. The clinical burden associated with the treatment of melanoma has been increasing due to a rising incidence of melanoma globally. In the past decade, at least 12 new drugs have been approved for unresectable melanoma, and at least 4 additional drugs have been approved for the adjuvant setting. Overall survival for melanoma is improving rapidly, with dramatic increases in long-term survival observed from administration of these new therapies. This guideline includes recommendations on uveal melanoma based on new clinical trial data. Recommendations. Please note that this is a living guideline, and the recommendations may change again between the time of recording this video in September 2023 and the time you are viewing it. You can always reference the Guideline Central website as well as JCO and the ASCO website to ensure that you have access to the most current version of this guideline. For all recommendations where multiple therapy choices were presented, you can see the Clinical Interpretation section in the full text guideline for more details on shared decision-making with patients. You can also see the dosing tables presented in the full text guideline for recommended dosing and scheduling details. These tables will also be covered later on in the video. With that background covered, we will now get into the recommendations. Neoadjuvant systemic therapy. Cutaneous melanoma eligible for resection. Recommendation 1.1. Neoadjuvant pembrolizumab, a maximum of 3 courses of 200 milligrams once every 3 weeks, followed by resection and adjuvant pembrolizumab, a maximum of 15 courses of 200 milligrams once every 3 weeks, should be offered to patients with clinical and resectable stage 3B to 4 cutaneous melanoma. This is a strong recommendation, evidence-based, moderate evidence, with the benefits outweighing the harms. Recommendation 1.2. Patients with clinical and resectable stage 3B to 4 cutaneous melanoma should be offered or referred for enrollment in clinical trials of neoadjuvant therapy where possible. This is a strong recommendation, informal consensus. Adjuvant systemic therapy. Resected stage 2, 3, and 4 cutaneous melanoma. Recommendation 2.1.1. Adjuvant pembrolizumab or nivolumab should be offered to patients with resected stage 2B or 2C melanoma. This is a strong recommendation, evidence-based, moderate evidence. Qualifying statement. The recommendation in favor of nivolumab is based at the time of writing on the conference abstract publication of Checkmate 76K and under the assumption that full publication of that data will not contradict the abstract. Recommendation 2.1.2. Adjuvant therapy should not be offered to patients with resected stage 2A melanoma outside of enrollment in a clinical trial. This is a strong recommendation, informal consensus. Recommendation 2.2. For patients with resected stage 3A to D disease that is BRAF wild type, the following adjuvant therapy options should be offered in no particular order: nivolumab for 52 weeks or pembrolizumab for 52 weeks. Ipilimumab and high-dose interferon are not recommended for routine use in adjuvant therapy. This is a strong recommendation, evidence-based, high evidence, benefits outweighing the harms. Qualifying statement. Patients with stage 3A disease with microscopic sentinel nodal metastasis less than 1 millimeter in diameter were not included in the randomized trials that studied efficacy of immune checkpoint inhibitors as adjuvant therapy for melanoma. Both nivolumab and pembrolizumab are U.S. FDA approved as adjuvant treatments for patients with melanoma with lymph node involvement who have undergone complete disease resection. Patients with stage 3A disease with less than 1 millimeter involvement in the sentinel lymph node have a relatively better prognosis and lower risk of relapse. Therefore, treatment should be individualized after discussing risks and benefits with these patients. Recommendation 2.3. For patients with resected stage 3A to D disease that is BRAF mutant, V600E or K, the following adjuvant therapy options should be offered in no particular order: nivolumab for 52 weeks, or pembrolizumab for 52 weeks, or dabrafenib plus trametinib for 52 weeks. This is a strong recommendation, evidence-based, high evidence, with the benefits outweighing the harms. Qualifying statement. Patients with stage 3A disease with microscopic sentinel nodal metastasis of less than 1 millimeter diameter were not included in the randomized trials that studied efficacy of immune checkpoint inhibitors and BRAF-targeted agents as adjuvant therapy for melanoma. Nivolumab, pembrolizumab, and dabrafenib plus trametinib are FDA-approved as adjuvant treatments for patients with melanoma with lymph node involvement who have undergone complete resection of their disease. Patients with stage 3A disease with less than 1 millimeter involvement in the sentinel lymph node usually have a good prognosis and low risk of relapse. Therefore, treatment should be individualized after discussing risk-benefit quotient with these patients. Recommendation 2.4. No recommendation can be made for or against adjuvant BRAF MEK inhibitor therapy in patients with resected stage 3 to 4 melanoma with BRAF mutations other than V600E-K. No recommendation, low evidence. Recommendation 2.5.1. Patients with resected stage 4 melanoma should be offered adjuvant therapy. This is a strong recommendation, informal consensus with moderate evidence. Recommendation 2.5.2. Reasonable options for therapy are either nivolumab alone with moderate evidence, nivolumab plus ipilimumab followed by nivolumab, low evidence, pembrolizumab alone, low evidence, and dabrafenib plus trametinib in patients with BRAF V600E/K disease with low evidence. All recommendations are weak and informal consensus. Systemic therapy. Unresectable metastatic cutaneous melanoma. Recommendation 3.1. For patients with BRAF wild type, unresectable and/or metastatic cutaneous melanoma, the following treatment options should be offered in no particular order: nivolumab plus ipilimumab followed by nivolumab, or nivolumab plus relatlimab, or nivolumab, or pembrolizumab. This is a strong recommendation, evidence-based, with high evidence, and the benefits outweigh the harms. Recommendation 3.2.1. For patients with BRAF mutant V600 unresectable and/or metastatic cutaneous melanoma, one of the following treatment options should be offered as first-line therapy: nivolumab plus ipilimumab followed by nivolumab, or nivolumab plus relatlimab, or nivolumab, or pembrolizumab, or dabrafenib plus trametinib, or encorafenib plus binimetinib, or vemurafenib plus cobimetinib. This is a strong recommendation, evidence-based, high evidence, with the benefits outweighing the harms. Recommendation 3.2.2. Combination therapy with nivolumab plus ipilimumab is preferred as first-line therapy over BRAF MEK inhibitor combination therapy, dabrafenib plus trametinib. High evidence. Combination therapy with nivolumab plus ipilimumab is preferred as first-line therapy over BRAF MEK inhibitor combination therapy. This is low evidence. Both are strong recommendations and evidence-based. Recommendation 3.3. After progression on anti-PD-1 based therapy, patients with unresectable and/or metastatic BRAF wild-type cutaneous melanoma may be offered ipilimumab or ipilimumab-containing regimens. Patients should be offered or referred for enrollment in clinical trials where possible. This is a weak recommendation, informal consensus with low evidence. Recommendation 3.4. After progression on first-line anti-PD-1 based therapy, patients with BRAF mutant V600 unresectable and/or metastatic cutaneous melanoma may be offered combination BRAF MEK inhibitor therapy as described in Recommendation 3.2.1. Similarly, those who have progressed after combination BRAF MEK inhibitor therapy may be offered anti-PD-1 based therapy as described in Recommendation 3.2.1. This is a weak recommendation, informal consensus with low evidence. Recommendation 3.5. For patients with injectable, cutaneous or subcutaneous or nodal, unresectable lesions who are not eligible or do not desire the recommended systemic therapies, TVEC may be offered as primary therapy. This is a weak recommendation, evidence-based, with low evidence, and the benefits outweigh the harms. Non-cutaneous melanoma, stage 2 or greater. Recommendation 4.1.1. HLA-A0201 positive patients with metastatic uveal melanoma should be offered tebentafusp. This is a strong recommendation, evidence-based, with moderate evidence, and the benefits outweigh the harms. Recommendation 4.1.2. For all patients with uveal melanoma, other than those addressed by Recommendation 4.1.1, no recommendation for or against any specific systemic therapy may be made at this time. Patients should be offered or referred for enrollment in clinical trials where possible. There is no recommendations, and this is very low evidence. Recommendation 4.2. In the absence of further data, the consensus of the expert panel is that patients with unresectable and/or metastatic mucosal melanoma may be offered therapy as described in Recommendations 3.1 through 3.5. Patients should be offered or referred for enrollment in clinical trials where possible. This is a weak recommendation, informal consensus with very low evidence. Recommendation 4.3. No recommendation for or against any specific systemic therapy for patients with any other form of non-cutaneous melanoma may be made at this time. Patients should be offered or referred for enrollment in clinical trials where possible. No recommendation. Tables and algorithm. Table 1. Reasonable dose and schedule details for recommended neoadjuvant and adjuvant therapy regimens. Table 2. Reasonable dose and schedule details for recommended unresectable and/or metastatic disease regimens. Figure 1. Systemic therapy for melanoma. So, there you have it, a recap of the current ASCO guidelines for systemic therapy for melanoma, including the newest recommendations from the August 2023 Rapid Update. For more information on this guideline or to access the guideline summary, pocket guide, patient summaries, or any other great ASCO resources, visit us online at GuidelineCentral.com or download the Guideline Central mobile app available on iOS and Android devices. Until next time.